Good day, everyone. Welcome to our panelists, our specially invited guests, ladies and gentlemen. Welcome to our webinar, which is focused on mental health, tobacco, and nicotine cessation, the second in the NATI series of webinars aimed at opening discussion on the interplay of smoking cessation and medical disciplines. I'm now going to invite our co-hosts to deliver opening remarks. We will first hear from Mrs. Miriam Chickering, CEO of nextgenu.org, and she will be followed by Dr. Kevin Severino on behalf of the American Academy of Addiction Psychiatry, our supporting partner for this webinar. Mrs. Chickering.
Thank you, Glenda. It's my pleasure to open this webinar on the mental health and tobacco cessation. This is the third webinar of the 2025 Nicotine Addiction and Tobacco Use Initiative webinar series. NATI is a network of networks of health profession associations and schools, as well as other partners aimed at addressing the current gap in tobacco cessation support and interventions, both from professionals and health systems, and also to counteract the tobacco industry's tobacco harm reduction narrative that is challenging tobacco cessation and tobacco control worldwide. NATI was launched in December of 2024. The Frank Foundation, through NextGenU's Addiction Training for Health Professionals initiative and the Center for International Cooperation on Tobacco Control, and the WHO FCTC Knowledge Hub in cooperation on tobacco dependence treatment of the Ministry of Health of Uruguay, lead NATI. The Frank Foundation's mission is to democratize education and improve the health of humanity and the planet. You can learn more about the Frank Foundation at nextgenu.org. This webinar is essential for NATI because, as we will see below, it addresses a population that is particularly affected by the problem of tobacco use and has not received the necessary care from health professionals. I hope you enjoy this webinar, and if you are not already a member of NATI, to join the network. Thank you.
Dr. Severino.
Hello, everyone. My name's Kevin Severino. I'm medical director for the American Academy of Addiction Psychiatry, which we for short call AAAP, and we're very pleased to be participating in this nicotine addiction and tobacco use treatment initiative. AAAP represents about 1,500 addiction psychiatrists. We are trained in general psychiatry for 4 years in the United States, and then after that, we have a 1 to 2 year fellowship specific to addictions treatment. So it's interesting that we focus a lot on opioids and a lot on psychostimulants. I do find in my own world that we don't pay as much attention to tobacco. And my contention is that actually kills our mental health patients far more frequently than many of the other effects of substance use disorders. I'm very pleased to be here. I'm also very pleased that you allow this to be conducted both in English and with Spanish translation, because I don't speak Spanish, but I hope you enjoy this webinar.
Thank you very much. I now have the pleasure of introducing to you Dr. Eduardo Bianco, Director of the Addiction Training for Health Professionals Initiative at nextgenu.org and co-coordinator of NATI, who will be our moderator today. Dr. Bianco.
Thank you very much, Glenda. Greetings to all the colleagues following the webinar and to those who signed up to receive the recording as they are currently working. We have today the privilege of having qualified professionals in the topic we are addressing, and really we are very happy to have them on board. With this webinar, obviously we don't intend for you to become an expert in treating people with mental illnesses who still use tobacco, but rather to understand the importance of treating them and motivate this audience to continue learning about the topic. I insist on if you are willing to raise questions to the presenters, please use the Q&A tool for that purpose. Having said that, I will have the honor of introducing our first speaker, Dr. Severino, who is the medical director of American Academy of Addiction Psychiatry, associate clinical professor of Yale School of Medicine, is certified by the American Board of Addiction Medicine, author of a large number of articles in prestigious magazines, and a speaker on numerous occasions at national, regional, and international level. Also, award-winning in many occasions. Dr. Severino will be speaking about tobacco use and mental health and an underestimated relationship. We have, as you saw Severino here, but we are going to show his recorded presentation. Please go ahead with the presentation.
Hello, my name is Kevin Severino. I'm medical director for the American Academy of Addiction Psychiatry, and proud to have that organization be involved in today's Nicotine Addiction and Tobacco Use Treatment Initiative webinar. My goal for today in the next 15 minutes is try to convince everyone treating mental health disorders that it's imperative that we put near the top of the list identifying and trying to treat tobacco use disorders. So I titled this An Unappreciated Relationship because in my experience, many mental health professionals will focus on the substance or the mental health issues such as depression that somebody comes in for treatment for and doesn't necessarily pay attention to tobacco use as much as, say, a primary care physician might. The first point I want to emphasize is that the rates of tobacco use are much higher in those with mental health disorders than those without. And conversely, the rates of mental health disorders are elevated in those who use tobacco. So there's a two-way street, and there's very high chances that the patients that you treat as mental health providers will have a tobacco use disorder. Let's look at some of these facts that I've kind of gathered together and looking through the literature. You can see that those that with any mental health disorder compared to those without have at least twice the rate of smoking. And this is worldwide in the United States, Australia, South Africa, and Singapore. And I put the references of these analyses down below. All the references for this are listed at the end of the talk. Another way to look at it is if one is smoking, what are the transition odds from that substance use to a mental illness? And you can see here that if you have a nicotine use disorder, you have something like a 4 times risk of going on to develop a mood disorder, an anxiety disorder, a personality disorder, or a psychotic disorder. And one thing that's interesting you'll note throughout this presentation is that the strongest association in progressing to a mental health disorder is with the psychotic disorders, which is interesting. We've known this association for a long time. So these are data from 2000 by Lasser et al. And you can see here that smoking prevalence in specific psychiatric diagnoses is highest for those that have other substance use disorders, but also very high for bipolar disorder and depression. And in fact, in this study, those with the lowest risk, those with panic disorder, were still twice as high in terms of smoking prevalence as those without a mental illness. How about we look at some more recent data? You can see here, this is from 2017, Hahn and Evans. You can see here smoking prevalence in specific diagnoses. Again, those with psychoses quite high, schizophrenia, and bipolar disorder, psychosis being in bipolar 1 mania, but very high in PTSD, major depression, and highest still in those with other substance use disorders. And that's compared to the general population, which again you see, except in this study for OCD, everything is at least twice the rate as in the general US population. So take-home message number one, if you treat mental illness or substance use disorders, you must screen for and address your patient's tobacco use, or in this day and age, nicotine use, because it could be vaping, could be tobacco punches, etc. Second point, tobacco use makes a substantial contribution to the excess morbidity and mortality in the psychiatric population. So you may treat somebody's depression, but if you don't pay attention to their comorbid physical conditions, including the preventable tobacco use, they still will have greatly excess morbidity and mortality. You may be, what are the reasons for this? Well, we know tobacco use in the United States accounts for about almost 500,000 deaths a year, or 1 in 5 deaths worldwide, and in the US, it's the leading cause of chronic obstructive pulmonary disease and lung cancer. Smoking has been deemed by many authorities the world's leading cause of preventable behavioral illness. And that falls behind sedentary lifestyle and obesity, which in many studies is not called a behavioral illness. Those who smoke have markedly elevated risks of alcohol and drug use disorders, as we said before, increasing the risk of comorbid medical illness, such as COPD. Conversely, 75% of those in treatment for SUD smoke cigarettes. So even though the general population in the United States is down to something like 13 to 14%, 75% of those in treatment are tobacco users. This contributes to the mortality gap. The pooled relative risk of dying in those with mental disorders is more than twice that in terms of mortality risk, relative risk, of the general population. 67.3% of those deaths were due to natural causes. So in other words, not suicide, not homicide. Average reduced years life in this study, which is Walker et al. 2015, just over 10 years. Numerous other meta-analyses and reviews in several countries support the increased risk of a physical diagnosis after the diagnosis of a mental illness. The association of poor health behaviors and environments with both mental illness and medical illness provides one explanation, and I would say provides the most logical explanation as to why we link the two. This is a nice study by Tam et al. That I like to point out. I'm just going to look at the darkest boxes in gray at the top, which is for both male and females. And you can see that those who have never smoked lose about, but have serious psychological distress, which is their proxy for psychiatric illness, die about 5.3 years younger than the general population. If you look, though, at current smokers, those current smokers without psychiatric illness die 8.8 years earlier. Those with psychiatric illness, almost 15 years earlier. Same with former smokers. Former smokers without mental illness, 3.4 years, and with mental illness, 9.1 years. So my point is that smoking robs you of years of life, and that is even worse in those with mental disorders. That's why we need to pay attention to this. Smoking greatly increases the mortality in the mentally ill. Comorbidities of cardiovascular and respiratory disease and cancer are major contributors to the mortality gap in the mentally ill, and these comorbidities are highly overrepresented in smokers. Tobacco use is if not the major preventable cause of the above conditions. And this is an example in East London, where a diagnosis of schizophrenia, schizoaffective disorder, or bipolar disorder had a rate of smoking of over 75%. There was an adjusted hazards ratio of mortality of the smokers versus non-smokers of about 1.4 for females, 1.5 for males, which accounted for the majority of years life lost. Tobacco-related conditions accounted for 53, 48, and 50% of deaths in those hospitalized for schizophrenia, bipolar disorder, and depression, respectively. in a study by Callahan in 2014. And the life expectancy of those with serious mental illness was reduced by almost 15 years compared to 5.3 years in non-smokers. And that's the data I just showed you from TAM. So smoking is a big deal in the mentally ill. So take-home message number 2, tobacco use is probably the major modifiable cause of disability and excess death in the world, even more so in the mentally ill. So you notice I say modifiable cause because there are other causes such as cardiovascular disease and obesity, which many would call much more difficult to modify than tobacco use. The last point, I don't want you to take a nihilistic view toward the ability to encourage smoking cessation in the mentally ill. Smoking cessation treatment is underutilized in the mentally ill because of that view, and yet it can work. So what are some of the barriers to smoking cessation in those with mental illness? Well, those with mental illness, first of all, face disparities in smoking cessation treatment. They often don't have the money. They may not have insurance coverage. They don't have transportation to get there. They may be in situations where so many people around them smoke that they don't feel it's worth the effort. Other barriers, psychiatrists and other mental health professionals are less likely to talk about quitting smoking with patients who have behavioral health conditions. This may be due to misperceptions about the patient's willingness or the ability to quit. And that's a study by Brown et al. In 2016, another study showed about half of mental health facilities and 2/3 of substance use treatment facilities screened patients for commercial tobacco use. However, fewer than half of the mental health and substance use treatment facilities in the United States offered proven treatments to help people quit smoking. So less than half used motivational interviewing and then tried to get people to accept medications to assist them in smoking. And the biggest excuse I hear from both patients and providers is, let me take care of, for example, my opioid use disorder or my panic disorder before I deal with the smoking. That is just not true. I was fortunate in the Connecticut VA, in their Newington branch, to take part in studies with Ned and Judy Cooney, which looked at the effect of concurrent smoking cessation treatment on rates of achieving alcohol abstinence. This wasn't reduced use, but abstinence. And those rates of actual alcohol abstinence were much improved when people were actually and succeeded at smoking cessation. So here are some of the reasons why we think that smoking cessation efforts in the mentally ill are not often used. It's believed that mental disorders, well, we know that mental disorders are linked to reduced quit rates, and I would argue that's because we don't make the attempt to have our patients quit. Comparing pooled data, this is a very often cited study by Creedon et al. In 2022, comparing pooled data from 2008 to 2009 and from 2018 to 2019, so a 10-year span. Current smoking rates of adults with mental health and substance use disorders decreased from 37.9 to 27.9%, while current smoking rates of adults without either mental health or substance use disorder decreased from 21.4 to 16.3. So they interpreted those numbers to mean that there was a significant decrease of almost 5 percentage points in those with mental health or substance disorder compared to those without, in terms of the percentage of those that stop smoking. But another way I look at it is, and here you see the data down here, that in fact, the rates are declining. Granted, they started from higher up, so this is a lower percentage compared to this, but you're succeeding in a significant number of cases. Recent data supports better success in those with major depression and other substance use disorders, though less so with psychosis. And this is a study by Beth Hahn, again, which shows that those with major depression versus those without depression both succeeded in rates of smoking cessation. And look at the difference, though. The difference is actually going down a little when you look at the numbers this way. And you might say, gee, this doesn't look very successful.
Smoking cessation is hard to do. If you get a 10 to 15% reduction in smoking, you've made a huge impact on the population overall. And for those that do succeed in quitting smoking, you've made a huge impact. Remember, on average, a person takes about 8 quit attempts before they succeed in quitting. What are some of the myths about smoking cessation? 1, tobacco users with mental illness aren't ready to quit as non-smokers, and quit attempts, successful or not, do not, it's believed they impair mental health recovery, and that is not true. The Closing the Gap Health Study supports those with serious mental illness as motivated to modify high-risk behaviors to improve their health. Quitting smoking, as opposed to worsening it, improves symptoms of depression, anxiety, and stress. Both bupropion and varenicline have been shown efficacious in smoking cessation in the mentally ill, and treating tobacco use disorder improves long-term abstinence from other substances and improves the mental health course. So take-home message number 3, I find it hard to understand how mental health workers do not target smoking cessation as both critical and as a low-lying fruit in terms of trying to improve the overall health of our patients. And I include a quotation by Wilson Compton in 2017, where he argues that smoking cessation should be a critical part of psychiatric care. He says, quote, evidence clearly supports the need to address tobacco use in patients being treated for behavioral health issues, end quote. And I thank you very much for your kind attention. I've included here where you want more additional information for our references. Thank you very much.
Thank you, Dr. Severino, for this excellent presentation that had highlight the urgent responsibility we have as healthcare professionals to help people with mental health disorder to stop using tobacco products. I forgot to mention that we have 335 people registered for attending the webinar. I know we are in different time zones, and many of them are working, but they are interested on having this recording. So let's go to our next speaker, Dr. Tony George. Dr. George is a senior scientist at CAMH, the Center for Addiction and Mental Health, the largest mental health and addiction teaching hospital in Canada, a renowned international center. Dr. George is a professor of psychiatry at Temerty Faculty of Medicine, University of Toronto. He has publishes over 350 peer-reviewed articles, and he wrote the chapter on nicotine and tobacco in Cecil textbook of medicine, the last 4 editions, and is the co-principal editor for Pharmacology Journal. He is going to address the topic of neurobiology of nicotine and tobacco, implication for people with mental health. As I told you, we have the recording of his presentation, but then Dr. George, he has joined the webinar, will address questions and interact with us. Please run the presentation.
Welcome to my talk on the neurobiology of nicotine addiction as relevant to mental illness. I am a professor of psychiatry at the University of Toronto and a senior scientist at CAMH, as well as co-principal editor of the journal Neuropsychopharmacology, or NPP. These are my disclosures. I just want to, again, highlight Dr. Severino's presentation and point out clinically the high rates of smoking amongst people with mental illness and addictive disorders. This is a slide from my group from about 15 years ago now, but I think the message is clear. The higher rates of tobacco smoking in people with mental health and addictive disorders compared to the U.S. general population. What we do know about tobacco addiction is there's a very well-defined neurobiology through the nicotinic acetylcholine receptor. When I started out studying this as a medical student, we knew much more about the muscle type that are involved in muscular contraction. Of course, we know the disorder myasthenia gravis is related to antibodies that block transmission through the nicotinic receptor in skeletal muscle. However, there is a very, very well-developed set of science now about the brain central nicotinic receptors, and these are ion channels ligand gated by acetylcholine, which is the acetylcholine is the endogenous transmitter, and nicotine, of course, acts in place of acetylcholine towards what we know as nicotine addiction. There is one particular kind of the brain composed of so-called alpha and beta subunits, alpha 4 beta 2 in particular, that's gotten a lot of attention in nicotine addiction. Just to relate that to serious mental illness, this is a slide from about 20 years ago from Bob Friedman, who was then the chair of psychiatry at the University of Colorado and a well-known expert in schizophrenia related to nicotinic receptor dysfunction. And what Bob and many others in the schizophrenia field have shown is that there are very elegant neurotransmitter relationships between dopamine, glutamate, GABA, and nicotinic receptors regulate all of these pathways, either directly or indirectly. This is a slide from a paper we wrote about 20 years ago when I was at Yale, and that's where I met Dr. Severino. And this is primary and secondary factors that we know are involved in tobacco addiction. So we know there's the acute withdrawal syndrome, there's the regulation of negative affective states or mood modulation, there are positive effects like reinforcement and satisfaction, and then there are conditioned cues that often lead to relapse, and these contribute to smoking maintenance and relapse. However, what we do know is that various transmitter systems, including dopamine, endogenous opioids, GABA, glutamate, serotonin, and several other peptides, may be involved in modulating these effects of nicotine, both primarily and secondarily. There's also other effects that are very relevant to mental illness, stress, weight control, cognitive enhancement, that may well factor in and are related to neurotransmitter dysfunction associated with tobacco addiction and various psychiatric disorders. Just to put it all together, this is an old slide of mine now from about 15 years ago, looking at the total package of factors that lead to tobacco addiction vulnerability in at least people with schizophrenia. This is the best characterized disorder when it comes to nicotinic receptor dysfunction and smoking. And this is just a summary of genetic, environmental, and other causative factors, neurobiologic factors that may lead to the ultimate clinical manifestations of tobacco addiction and nicotine dependence in people with schizophrenia. So this is a brief summary from that same article published 15 years ago by Vicky Wing. Colleagues, Vicky was a postdoc in my lab. And these are a summary of biobehavioral factors that contribute to tobacco addiction and schizophrenia. So we know there are reduced expression of nicotinic receptor levels associated with the brains of people with schizophrenia. This is primarily through something known as the alpha 7 nicotinic receptor, a particular subtype of nicotinic receptors that is involved in sensory gating associated with schizophrenia. There's deficits in sensory gating, and it's known that nicotine and nicotine-like drugs can rectify those gating deficits, known as the P50 response, in people with schizophrenia. There are also known deficits in reinforcement. We've done a number of studies over the years looking at that, and we know there are clear pro-cognitive effects and pro-physiologic effects of nicotine in people with schizophrenia and possibly other mental illness that may contribute to addiction vulnerability to nicotine in these patients. So this was an old study now, 25 years ago. I did it when I was a junior faculty member at Yale, and we looked at a dopamine sensitive cognitive task called visual spatial working memory. So this is the ability to hold a representation in one's mind and then have something to distract you, and allows one to localize where the object was. It's a well-known deficit in people with schizophrenia. So these are two groups of smokers with schizophrenia, one with schizophrenia on the left-hand side, and on the right-hand side, these are healthy, non-psychiatric controls. And so the higher the scores, the more deficit in this working memory task, the VSWM task. And what we were able to show in 23 smokers with schizophrenia is that when they quit, they actually had further worsening of this working memory deficit. But in fact, it was just the opposite in controls. They actually had an improvement when they quit. So there's this diagnosis-specific difference in um, um, working memory function with quitting smoking, depending on whether you had schizophrenia or not, and suggested that there's clear dopaminergic dysfunction that's regulated by nicotine in this disorder. We went on to show that this deficit actually is clinical reference. This is one of my former graduate students, Taryn Moss, who's now a clinical psychologist here in Toronto. And a set of studies initially that two postdocs of mine, Sarah Dolan and Christy Sago at Yale, did. And they showed that in smokers with schizophrenia who quit, at baseline before they quit, there was better cognitive functioning on this working visual-spatial working memory task. So that is to say, those smokers with schizophrenia who quit had better baseline dopaminergic function than those who didn't quit. Taryn went on to further extend this work, showing that in two other executive cognitive tests, the trail-making test B and the digit span backward, that this was very similar. So better performance on these tasks was associated with better performance on these cognitive tasks was associated with quitting smoking. Positively speaking, there's a positive correlation. All right, so in my final few minutes, I just wanted to talk a little bit about the approach that we take with smokers with mental illness based on this, a model of dopaminergic and nicotinic dysfunction. And one of the important clinical questions that comes right up is whether we should be getting these people to quit entirely, or should we take a harm reduction approach? And so is reduced smoking a viable target? And so I will just remind you that one of the things that we want to consider in clinical tobacco addiction treatment is whether we should get people to quit right away or get them to cut down and transition towards eventually quitting. What I will say is that sustained reductions do not lead to significant reductions in cancer risk and cardiovascular disease. So ultimately, clinically, even these difficult to treat patients, we should be trying to get them to quit. Another clinical issue that comes up related to how smoking affects liver enzymes, and in particular, one called CYP1A2 and another related one, CYP3A4. Many of the psychiatric medications that our patients takes though their metabolism is induced by cigarette smoking, not by nicotine per se, but many of the carcinogens, non-nicotinic factors, which are primarily carcinogens, benzoyl, pyrene, etc. And that is associated with increased metabolism of certain drugs like clozapine, olanzapine, haloperidol, and even caffeine, but not with other medications such as bupropion, SSRIs, risperidone, aripiprazole, quetiapine. So there's just something to keep in mind as we approach the treatment of these patients in terms of getting them to quit. Now, I'll show you this study. This is an evidence-based study, one of the first ones. This was an R01 grant I had at Yale almost 20 years ago now. And we looked at whether the smoking cessation drug bupropion could enhance smoking cessation outcomes when it was combined with a patch. And we did this with a placebo-controlled design. So everybody got the nicotine patch, and then we randomized people to either bupropion, which is Zyban, or placebo. And what we found is almost a tripling of the quit rates in those who took the bupropion, Zyban, compared to placebo. And interestingly, even 6 months after we stopped the treatment, if we looked at smoking cessation outcomes, while many of those people had relapsed, there was still a huge difference in terms of keeping people smoke-free if they had been treated with bupropion versus placebo. Of course, almost 20 years ago now, in 2006, the FDA approved varenicline, also known as Champex in Canada. That was approved the next year. And so the evidence is actually pretty strong that Champex, typical 24 weeks of Champex, and even extensions of that at doses up to 2 milligrams a day, is very effective and safe for getting smokers to quit. One of the big questions is this drug safe in patients? So beyond the typical side effects, which are usually GI, nausea, also abnormal dreams, there are least in the early stages of treatment with this drug, there were black box warnings issued by the FDA, Health Committee, and the European medication regulators, suggesting that there was treatment-emergent suicidality, homicidality, and aggression associated with this drug, as well as psychosis and even mania. So I was involved with one of the first studies to look at safety, and this was a group of people, randomized 127 with schizophrenia, smokers with schizophrenia, randomized to either varenicline or placebo. And what we found is almost quadrupling of the quit rate at both 12 and 24 weeks. And fortunately, when we looked at safety outcomes, this is just one graph that shows safety. Looking at positive and negative symptoms of schizophrenia, positive symptoms being delusions, hallucinations, thought disorder, the kind of things that get people hospitalized. And negative symptoms, anhedonia, avolition, difficult social relationships, the things that cause the true dysfunction associated with having schizophrenia. Those didn't change across 24 weeks of treatment. In fact, we followed these people for a year and even 2 years, and there was no evidence that there was a problem in terms of safety. Eden Evans, my colleague at Massachusetts General Mass Brigham, did a complementary study. She looked at the use of varenicline as a relapse prevention agent, people with schizophrenia, schizoaffective disorder, even bipolar disorder, and found very nice study, very lovely study, that once you got people to quit and then randomized them to either 2 milligrams of varenicline or placebo, that varenicline prevented smoking relapse very effectively with a very large effect size. So very effective in quitting smoking, very effective in promoting smoking, preventing smoking lapse or preventing smoking relapse in people with schizophrenia. Then you may know of this very large study by Rob Antonelli and colleagues, and both Ian and I were part of this study, called the EAGLE study, which was a very, very, very large study with over 8,000 people comparing varenicline to bupropion to nicotine patch and placebo for smoking cessation among mentally ill smokers and a large group of controls. This was everything from schizophrenia to borderline personality, mood disorders, PTSD. Bottom line, very safe and actually very effective in all these smokers. And so this was published in The Lancet now almost 10 years ago. I'll just very briefly touch on varenicline and bipolar disorder. This is Roy Chegupa, and I was involved with a study over 10 years ago now that showed the effectiveness and safety of varenicline for treating bipolar disorder. And importantly, it didn't lead to bipolar relapse, and in fact, got people to quit and helped them stay quit. So this drug and bupropion, when used properly in stabilized patients, can be very safe and effective for treating tobacco addiction in these patients. I'll just finish with one novel area that we've been exploring over the past 15 years now, and this is brain stimulation with repetitive transcranial magnetic stimulation. And so this is an old postdoc of mine, Carolyn Voss, who's now a psychiatrist in Sweden, and showing how we place the coil, the figure 8 coil, over the frontal lobes. In fact, we do bilateral stimulation of the frontal lobes in our treatment paradigm at GAMH. This was one of the early findings we had, very exciting, that in a paradigm where we can induce tobacco craving in people with schizophrenia, active RTMS at 20 hertz could completely block the increase of craving that we would get with 30 minutes of abstinence, versus in the sham condition, you saw the big increase in craving. So RTMS applied bilaterally to the frontal lobes could block those effects. I'll just mention one last thing. Vaping e-cigarettes has now become very common in society. In fact, 30 to 40% of the nicotine misuse market is now vaping, maybe more now. And that's certainly the case in people with schizophrenia. E-cigarettes have been proposed as a potential harm reduction strategy in people with schizophrenia spectrum disorder. There are 2 promising open label studies that are in the literature now, and I think a few others that are still in progress. But this is very controversial, although I would say that using vapes, using e-cigarettes is probably safer in the long term for people with schizophrenia than is tobacco. So just to summarize, just to finish up, the burden of tobacco use and vaping is very high in people with mental illness, and I've shown you mostly data in people with schizophrenia. And despite the fact that the rates of smoking in the general population are decreasing, this has not transcended to people with serious mental illness like schizophrenia. So there's a big problem, patients, families, and the health system, as this is a very devastating contributor to morbidity and mortality in these patients. However, based on some of the data I presented about the neuroscience underlying tobacco addiction in people with schizophrenia, I hope that this helps you understand how a rational approach based on understanding the pathophysiology of tobacco addiction and mental illness can potentially lead to promising treatment outcomes related.
Thank you very much, Professor, for this excellent presentation. I would like now to introduce, please remember, if you have questions for Professor George, please put in the chat, in the question and answer box, that we will try to reply most of them at least. It's important what Dr. George has raised, that we already have excellent pharmacological treatment for addressing tobacco users with mental health disorders. So now we are going to move to our next expert, Professor Stanton Glantz. He is a renowned international tobacco control expert with expertise in the health effects of secondhand smoke, e-cigarette, biostatistics, and the tobacco industry tactics against public health policies. Professor Glant is a former full professor of medicine at the University of California, UCF, and founder and director of the Center for Tobacco Control Research and Education at this university. Glantz is author of numerous publications, including the Cigarette Papers, and a foundational figure in making the industry's internal document public. So let's listen now to Dr. Glantz's lecture.
Hello, my name is Stanton Glantz. I'm a retired professor of medicine at the University of California, San Francisco, and I'm going to talk about the idea that e-cigarettes promote harm reduction and are effective smoking cessation products that are promoted by tobacco companies, and why those arguments are just not correct, that e-cigarettes, in fact, keep people smoking and are not substantially safer than cigarettes. Now, the argument for e-cigarettes is quite simple. It's that they deliver inhaled nicotine without burning the tobacco. And so you avoid a lot of the toxic combustion products produced by burning tobacco in cigarettes and other combusted tobacco products. And because you don't get those toxic chemicals, people who would switch completely from e-cigarette or from cigarettes to e-cigarettes are better off. And those arguments are not completely ridiculous, but what I'm going to show you is that they're actually not supported by the evidence. Now, the important thing to look at is the fact that we know a lot more about e-cigarettes than we did back in the early 2000s when they were first introduced commercially. And this idea that e-cigarettes are dramatically safer than cigarettes came from a paper published in about 2013 from a group of so-called experts, most of whom had connections to the tobacco and e-cigarette industries. And the important thing is that argument was completely theoretical. It was not based on any empirical evidence. And in contrast to that, we have a huge amount of empirical evidence, nearly 12,000 papers about e-cigarettes. And importantly, the first studies of e-cigarettes and disease risk didn't appear until about 2017, long after this idea that e-cigarettes are dramatically safer than cigarettes really got established. Another important thing is there's a very strong myth out there that e-cigarettes were developed for smoking cessation as a safer alternative to cigarettes. And most people think e-cigarettes were developed in the early 2000s in China as a way to help people quit smoking. In fact, the reality is that the big tobacco companies were working on e-cigarettes or similar technologies for a long time before that. And in fact, the first practical e-cigarette was developed by Philip Morris in the mid-1990s. And it wasn't developed for harm reduction. It wasn't developed for smoking cessation. It was developed as a way to hold on to customers, to health-concerned smokers who were quitting. And this picture shows from internal tobacco industry documents, and it shows the evolution of these products through the 1990s. And in fact, Philip Morris patented an e-cigarette in the mid-90s. It didn't take it to market for political reasons. They were afraid that if they were selling e-cigarettes as an alternative nicotine delivery device, it would help the FDA, the U.S. Food and Drug Administration, assert jurisdiction over cigarettes as drug delivery devices. Now, how should we be thinking about the health effects of these products? And as I said, the current arguments, which date back from the introduction of commercial e-cigarettes, and which you still hear very frequently today, is that e-cigarettes don't have combustion, so they produce less combustion products, and that reduces harm. And it's useful to look at how the Philip Morris Tobacco Company thinks that these products should be evaluated. This is a slide from a presentation that Philip Morris developed in 2004. And you can see that when these products are new, when they're first being developed in the first 6 to 12 months, that's how they said you should be evaluating them, is looking at the smoke chemistry and other things like that. But over time, as the products had been on the market for a while, their views changed. And they were saying that, well, after e-cigarettes or other potentially reduced harm products had been on the market for 5 years, the focus should shift to looking at epidemiology and human health effects. And that's something that the e-cigarette advocates, not just the tobacco companies, but well-meaning people in the health community, simply haven't done. And the argument that you hear is that, well, it's too soon, we don't have long-term evidence on e-cigarettes. But in fact, that's not true. We did a systematic review and meta-analysis of the population disease risks of e-cigarettes compared to cigarettes that we published last year. And this was based on 107 population studies that were available as of October 2023. So there's a quite robust literature out there, much broader and deeper than most people think. In fact, broader and deeper than I thought before we did this research. And the important thing we found in this paper was that there was no detectable difference in the disease risks of e-cigarettes compared to cigarettes for cardiovascular disease, stroke, metabolic dysfunction, and there was a slightly lower risk, but not a hugely lower risk for asthma, chronic obstructive pulmonary disease, and oral diseases. There were also studies of a lot of other outcomes, but we had part of our protocol was that we required at least 5 studies of a given outcome to do a quantitative meta-analysis, and these are the ones where there were 5 at the time. Also, if you scan the QR code, that'll bring up the paper. The other important thing we found was that dual use was always riskier than smoking. And dual use, that is using e-cigarettes and cigarettes at the same time, was quite common. The numbers varied from country to country, but the typical estimates in the United States are around 30 to 50% of these adult e-cigarette users are dual users. In other countries, the rates are even higher, up to 60 or 70%. And if you take into account dual use when assessing the overall disease risks of e-cigarettes, that is, looking at the effects of e-cigarette use among people who are just using e-cigarettes, plus the risk among dual users, what you find is overall there's a higher risk than just smoking for the average user. And that's true even for respiratory and oral diseases, where the risks of e-cigarettes by themselves are a little bit lower than cigarettes. So the conclusion or the assertion that e-cigarettes are dramatically safer than cigarettes is just not supported by the evidence. Now, you also hear that e-cigarettes are good for smoking cessation, and the source that's usually quoted from this is the Cochrane Collaborative, which has done a series of reviews of the randomized controlled trials comparing e-cigarette use to usually nicotine replacement therapy. And what they consistently find is that combined with counseling, giving people e-cigarettes is associated with a little bit higher rate of stopping cigarettes than with nicotine replacement therapy. And this is widely quoted. The important thing to keep in mind when thinking about the Cochrane Collaborative results is that these are clinical trials done under clinical supervision. The people in the trials are being monitored. Almost always they're being provided with smoking cessation counseling. And they, again, the results showed a better performance than nicotine replacement therapy. But an important result in these studies, if you look carefully at the results, and this is not something that people doing the studies have generally made a big deal out of, is that for every person who switches, that is, goes from e-cigarettes, or pardon me, from cigarettes to either e-cigarettes or to no tobacco use at all, you end up with around 2 to 4 dual users being created. So while if you get someone to switch from cigarettes to e-cigarettes, the risks for some outcomes, most notably respiratory disease, are a little bit better. You get many, many more people who become dual users, which even for respiratory disease and for every outcome, in fact, they're actually worse off than if they just kept smoking. So the net effect of giving people e-cigarettes as a smoking cessation intervention is to actually increase harm because you're promoting dual use. The important thing, though, is that e-cigarettes are not medicines. There is no country in the world that I know of where e-cigarettes have been authorized by the medicines authorities like the FDA here in the United States as medically approved smoking cessation interventions with a positive risk-benefit ratio. E-cigarettes are consumer products where in countries where they're legal, people can just go to a store and buy them and use them however they want. And so the real important question is not, are e-cigarettes, do they have efficacy in a clinical trial? The real important question is what goes on in the real world. And there's a quite large literature available on this. This is from a meta-analysis we published 4 years ago when there were about 70 or so studies of e-cigarettes and stopping cigarettes. And what we found was that there was no association between e-cigarette use as consumer products and stopping cigarettes. And there have been other meta-analyses with more studies done since then that found the same thing. So what are the implications of this for clinicians and regulators? Well, first of all, e-cigarettes are not effective for harm reduction. The risks they bring are nearly as large as cigarettes, and when you consider dual use, they are larger than cigarettes. So the whole idea that you should be promoting e-cigarettes as a way to reduce the harm of inhaling tobacco is just not supported by the evidence. And as I said, for many diseases, e-cigarettes by themselves are indistinguishable from smoking. Dual use is worse than just smoking, And e-cigarettes are not approved as cessation medicines anywhere in the world. And in fact, what they do is they keep people smoking and promote dual use, which is why the tobacco companies developed them in the first place. So thank you for your attention, and I'm happy to take any questions.
Thank you very much, Professor Glant, for this excellent presentation, because it's one of the objectives of NATI to prevent tobacco industry narrative, and also because it was requested for many NATI members this topic. So now we are moving to our main panelists, who first of all, if you are in English, well, I think you wouldn't need to change channel, because our next speaker, Dr. Ricardo Gotti, Chief of Mental Health Department of the Ministry of Health of Panama, will be providing comments on the excellent presentation we already listened, and then we are going to move to our question and answer segment, and we will have all the speakers to address the question. Please, Dr. Ricardo Gotti, open your mic, and you are there, and start your comment.
Thank you. Well, thanks to the translation, we'll be able to speak Spanish and you'll be able to hear. We had 3 outstanding speakers that shared information that is highly valuable for all of us interested in the use of tobacco and its impact on health. Dr. Severino discussed how there's enough evidence of the relation between smoking and mental illness, something that we, all healthcare professionals, but especially mental health professionals, should care about, because it's a legal drug. Tobacco is illegal almost around the world, just as alcohol, and maybe that gave us a social view of tolerance that is not good for our patients, that may be affected both in their physical and in their mental health because of the use of these products. So this is an invitation for all of us to pay close attention to whether patients use tobacco, but even more significantly so in those people that we care for, that have mental disease or problems because of other addictions. Tobacco is the most important modifiable cause of death and preventable at a global level. So we should feel committed to promoting tobacco cessation to improve the population's health standards. Dr. George very clearly explained the neurobiology, how addiction to tobacco, to nicotine works, and how the use of tobacco interferes with the metabolisms of certain medications that we use in psychiatry. But now, speaking of mental disorders, but they're not the only medications whose metabolism may be altered because of the use of tobacco. And that they also told us that there are effective treatments to treat nicotine addiction. And Dr. Glantz also brought us very clear evidence to remind us that the discourse of harm reduction is not a discourse that may be supported by scientific evidence in the light of our current knowledge. And certainly, these products have not been in the market for a long time, and there's still a lot to see and to discover about them in terms of the way they build up, their effects build up with time. As time goes by, it is important to note that these are not medication. It's not accepted as a medication for cessation, but rather that it ends up in a dual use. So vaping is used together with smoking. The patient ends up using both. Panama is the country that is a bit as an outlier because in our last national health survey in 2019, they say that the prevalence of tobacco of smoking is 5% in adults. And since we joined the CMCT since 2008, we have a support in a customer, and we have regulations that have highly contributed to tobacco control in Panama. So our patients, the hospitals, are not usually using tobacco products. But as we have high taxes, it is difficult for them to obtain the products legally because of the cost. All of these measures contribute to make our task easier. However, even if we have just 5%, as long as there are people that smoke and people with mental disorders using tobacco products, we are not doing our best to help preserve a basic human right, that is health, that we should all commit to. We know how much damage tobacco produces directly and also as secondhand smoking. So opportunities like this today are very valuable so that we can warn the healthcare professionals how important it is to do something about tobacco use among the people with mental illness. This is something that we wanted to do, and we wanted to give some time for Q&A. So if you listen to this presentations, you have a chance to ask questions. It will be the floor.
Thank you very much, Dr. Gotti. Please, the speaker, open the mic and camera so we can see you. And please quit this slide presentation. I'm not clear because Dr. George, here you are, Professor George. Thank you for staying a little more because I received your message that you need to go. So if you could receive a very first question, and so feel free to go when you need. It is related to behavioral treatment in people with mental illnesses, because we were talking about medications, but not so much in relation to behavioral treatment. Could you elaborate something or a little more on the importance of this for tobacco cessation, please?
Yeah, I think it's critically important. I focused on medications, but what I didn't say is that all of the studies we did and any clinical treatment we do involve sort of, standard behavioral treatment. So motivating people to engage in treatment, and then teaching them the skills to quit. So what I would say is there's nothing unique about the behavioral treatments we do for mentally ill smokers compared to general smokers. We do perhaps do more repetition of some of the basic skills, given the cognitive deficits these people have. But yeah, it's a critical part of that, but there's really no difference in what we do.
Excellent. Thank you. One more in order to allow you to go if you need. What when you should start the tobacco cessation in a patient with mental health problems?
When?
It's a question also for Dr. Severino.
I would say as soon as possible. When we are treating people, stabilizing symptomatology. I mean, the information or the data on when to do it when someone's acutely ill. I think practically speaking, you want to do it as early as you can. But if someone is acutely psychotic, manic, depressed, their motivation may be affected to try to address their tobacco use. So we generally advise that you get these people relatively stable, and then start the tobacco interventions. I also would not want to give the medications like varenicline and bupropion to someone who's acutely ill. The studies that I showed safety data on were in stabilized patients, but there is evidence that these drugs in acutely ill people could potentially worsen things. There is that risk of that. So as soon as you can motivate and get someone to do that, but I would say once they're relatively stabilized in terms of, so I would not typically do this in inpatients, other than, the basic, if you can get, smoking awareness groups there, that'd be great. But typically this is an outpatient proposition, I would say.
So
And
this
I,
Thank
is
you.
I,
Glenn.
I'd
Thank you very
agree.
much. Yes, please,
Can
Kevin.
I ask a question before Dr. George leaves? The one of the things that I've heard, I mean, there is a pretty good literature now showing an association between e-cigarette use and mental health problems, including in kids. And the e-cigarette advocates say, well, that's actually reverse causation because they're using the e-cigarettes to get nicotine to self-treat their mental health problem. So that's what's going on. Whereas your presentation seemed to suggest that the nicotine is causing the problems. And so it may be that both are going on, but could you just talk about the directionality of that relationship based on the biology that you discussed?
Sorry, the nicotine causing what problems?
That the nicotine, causing a variety of mental health problems.
Yeah.
Went through several in your presentation.
So what I would say is that, like I completely agree that, tobacco, nicotine, bad for the health of these people. Thank you for sharing, your most recent analyses. Um, what I would say is there is some evidence, though, that nicotine can have positive effects on the underlying pathophysiology of these disorders. And what I would suggest is that what makes them vulnerable to nicotine and tobacco addiction. But obviously, this is a leading killer of our patients, whether it be nicotine through tobacco or nicotine through e-cigarettes. But what I'm saying is that the increased vulnerability to nicotine and tobacco addiction in people with mental illness like schizophrenia, where the data is best, could be because nicotine itself may be remedying some of the underlying illness, the pathophysiological aspects, the neurophysiological deficits, the cognitive deficits. So thank you for that. That's an important thing to clarify.
Well, so are you saying, I don't want to beat a dead horse here, but this is something because I don't know much about this. Are you saying that people are primarily the association that people are seeing is because they're using the nicotine as a self-treatment, or is the nicotine itself causing or making these conditions, the mental health conditions, worse, or are both things going on?
Possibly both. I would say the nicotine is not per se making the mental illness worse. And it's not, I don't like to think it's self-medication, but I'd say it's a vulnerability. So if nicotine itself is rectifying some of these nicotinergic deficits associated with illnesses like schizophrenia, then I think it's a risk factor. You could argue it's self-medication. Some people have, but what I would say is when these people stop, they actually there's more benefits to stopping than there is to not stopping. So it's a tricky sort of double-edged sword here. The point I'm trying to make is mostly that nicotine is a vulnerability factor, or nicotinic deficits are a vulnerability factor that may explain the addiction to higher levels of nicotine use in these people.
Thank you both. I would like to listen to Dr. Kevin Severino. It's obvious that we need more research in many aspects related to mental health, But I'm very happy that about your interaction, and that was we were willing with this kind of webinar. Thank you both, really. And Dr. George, feel free to go when you need. Thank you very, very much. Kevin, please, let's listen to your input.
I wanted to ask Dr. George first before he heads off to the next hockey game or whatnot. Given it's a partial agonist, would varenicline partially ameliorate or substitute for nicotine's effects on some of the beneficial effects in schizophrenia?
I don't think that's particularly been well studied. That's the presumption that we looked at. In fact, we looked at that working memory task
Mhm.
years ago. I didn't show this data with varenicline, and it partially rectified the effects of nicotine. So is that because of the partial agonist effects? The 2 milligram dose, maybe you were getting, true a partial effect. On the other hand, with a partial agonist, you push the dose up, it should block those effects. So I'm not really sure what the answer would be to that.
Okay, thanks. I think these were excellent presentations. I always learn a lot. Some of this information for me is new in what Dr. Glantz presented. I wanted to just, for those that are not familiar with the effects of some of the combustion products of tobacco, the cyclic, what do we call them? PAHs, polycyclic aromatic hydrocarbons. So they induce 1A2, cytochrome P450 1A2. So you have to particularly pay attention to inpatients who are stabilized that then go back out and start smoking again. And so you've got to pay attention to. So many of these people, if they start smoking again, will reduce their levels of some of our psychiatric medicines. And the most important ones, I think, are clozapine and its chemical sister olanzapine. I saw one study where, in fact, increasing smoking again would reduce by about a third the level of clozapine. So the patient may go out, smoke again, and relapse to psychosis. If you can stop them from smoking, you may be able to reduce the dose of clozapine, which could be a very good thing in terms of weight gain and other effects. But some of the other important ones, Haldol is another, haloperidol, and lithium. Surprisingly, smoking can actually increase lithium levels. As you've got to watch that. If you've ever lost a patient to lithium toxicity, that leaves a scar on you forever. Duloxetine's another. And then two medical things, affects the levels of Coumadin, warfarin, and affects the levels of beta blockers. So just pay attention to that when your patients are coming out of the hospital, or if you're succeeding at smoking cessation, you may find that you can decrease the level of some of these meds. We have any other questions, Dr. Bianco?
Yeah, we have one on sorry. We have one from Dr. Ivan Francisco Álvarez Orozco from Colombia. I would like to ask about your experience with adolescents with mental illness and nicotine addiction. I don't know if you, Kevin, you have experience on that, because Dr. Álvarez Orozco is a pediatrician.
Right. Well, what I can say is I've always treated adults, the physical adults, I would say mentally, many of the people in the United States don't achieve mental adulthood till sometime in their 40s. But at any rate, what I think is, so I do not have direct experience with that. However, I think it's very important to realize that nowadays, at least in the United States, more adolescents are initiating use of nicotine through vaping than for any other substance. So that's smoking, that's cannabis, that's alcohol. Nicotine vaping is being very widely used. And from my reading, it appears that that kind of nicotine tickling, so to speak, may be a gateway not only to other mental illness, I don't know if it's a cause or an effect, but also to the use of other substances. So to really pay attention, and I applaud your being a pediatrician that's on this initiative, because if we can stop that initiation of nicotine, or if it's like alcohol, at least delay it till they're significantly older, that would really help.
Yeah, this is Stan Glantz. These are two. There was a pretty big meta-analysis among youth, which I think were defined as people up to 24, where they looked at the association between e-cigarette use and mental health problems. And they actually found the association going in both directions. That people with diagnosed mental illness problems were more likely to use e-cigarettes, but also people who use these cigarettes were more likely to report mental illness. And the association in the direction of e-cigarettes being increasing mental illness risk was a bigger. So, you know, the way I've interpreted, and I don't know nearly as much as the other speakers about mental health, but is that the association does go both ways, but the e-cigarettes as a stimulus for mental health problems in youth is bigger than the use of it as a self-treatment or and in terms of the gateway effect, which Dr. Severino mentioned, there's a very large literature in that area now. There's like 50 or 60 or 70 studies, and they very consistently show that youth who initiate nicotine use with these cigarettes, which, as he said, is the main way kids initiate nicotine use now, it about quadruples, triples or quadruples the odds that later they'll go on and add cigarettes. And there's a smaller literature showing a similar effect for alcohol and marijuana.
And we all know we've always blamed cannabis as being the main gateway drug, but I don't think we should forget the literature on nicotine, which seems the most convincing to me.
Yeah, the other thing which is new, and there was just a paper published on this a month or two ago, is these nicotine pouches, which are like tea bags filled with they're a little bit like snus, but they're much stronger. And they actually use some of the technology that was developed for e-cigarettes and heated tobacco products. And those are really taking off among kids in the United, and they're available in flavors. The FDA has authorized some of them, and they seem to really be taking off among kids now.
Yeah, I think, in the classroom, if you put a pouch in your mouth, you don't have to worry about anybody going into the bathroom and realizing you're vaping. But it's like old-fashioned baseball players that always had a stick of chaw in their cheek. And I do worry there that we're going to start seeing, more oral cancers again. I think I saw Dr. Gotti had his hand up.
About the question of Dr. Alvarez of Colombia, it's really a challenge. Nicotine addiction and among adolescents with mental disease, that's very challenging. Although in Panama we don't have so many cases because people don't smoke so much, I would say that the experience has been more directed to prevention and adolescent-friendly clinics, so that the young may understand the risks that tobacco products entail, so that, and to address issues such as cardiovascular or pulmonary performance and the cosmetic part, explaining adolescents something that they care about, that is whether they'll have stains or. However, with regard to the mental health, we have to work in parallel, providing mental health care and at the same time raising awareness so that they will be more willing to quit smoking. We don't have much experience with drugs, with medications among adolescents, but I would say that we know that the adolescent's brain is developing, and when exposed to nicotine, is more prone to have learning problems or emotional regulation problems, or they will make them more prone for new addictions. So we have to approach both things at the same time whenever possible. This is the only thing that I wanted to say concerning adolescence. Thank you, Ricardo. We only have 5 minutes left. I don't know whether Kevin and Professor Stanton Glantz want to give a final message to this to wrap up.
Please, Kevin, start with your final comment.
I just want to emphasize for all of us treating mental illness that substance use disorders are not separate. They're part of mental illness, and that the emphasis on tobacco use disorder and tobacco use, and now we're learning with e-cigarettes, nicotine use, should be really high at the top of the list. And we're always dealing with, in the United States, the focus was for so long on opioid overdose deaths. Those are down to about 80,000 a year now, whereas we think almost 500,000, at least Americans a year, are dying from pretty direct smoking related causes. So let's please pay attention to that in our treatment of those with mental illness. And as Dr. George pointed out, especially varenicline and bupropion can be quite effective in these populations. Thank you.
Sorry, Kevin, there is a question from Dr. Elba Esteve from Uruguay regarding if the people with mental illness that are admitted to hospital should receive systematically nicotine replacement therapy independently of their motivation for promoting cessation. What do you think?
Well, in the United States, the standard is that hospitals are smoke-free institutions, and therefore they are pretty much always provided with a patch and sometimes with ad lib, lozenge, or gum. Now, in the rest of the world, I mean, in the old days when I first trained, which was when, dinosaurs roamed the earth, we would actually have smoking breaks for our mental health patients. We thought that was helpful. But now I'm not sure how, for example, in South America, what the standard approach is in a hospitalized patient. I would think that everybody should be given nicotine replacement therapy during the time they're in hospital and not smoke.
This is a topic for a next webinar in 2026 addressing tobacco user admitted to hospital. Stan, please, your final comment.
Well, I want to thank the other speakers. I actually learned quite a lot listening to them. I think the important point from the other speakers was that it's really important to treat nicotine addiction among people with mental illness. And the point that Dr. Severino made, that in fact it's smoking-induced diseases that kills people with mental illness more than the mental illness kills them. And this idea that you can't treat them or you shouldn't treat them until you've dealt with their underlying problems is just out of date and wrong. And excuse me. There was a really interesting study that one of our postdocs did, not with me, but when I was still running the Tobacco Center, where you hear that you can't really smoking and e-cigarette use and tobacco use among homeless people is really high, and as is mental illness problems. And one of the excuses that you heard was that, well, these people are just intractable, you can't treat them, they have so many other problems, you should do not worry about the tobacco. I mean, it was sort of the arguments you heard from Kevin on steroids. And this postdoc actually did a randomized controlled trial of using state of the art treatments for nicotine addiction on homeless people. And this included like tracking them down in the parks where they were sleeping under trees and stuff. And what he found was that while the nicotine use levels were very, very high among this group, that they were just as interested in quitting as the general population, and that if they were treated appropriately, they did as well as the people in the general population. And so, excuse me, I got a frog in my.
Don't worry, Stan. Take your time.
No, well, it just that. So, I mean, the message that you're giving is very important. With regard to my presentation, the key point is that the idea that e-cigarettes could be used for smoking cessation and harm reduction, which is very, very heavily promoted by the industry and by some people in the health community, is just wrong. There's a tremendous amount of evidence out there now on the health effects of e-cigarettes and the association with smoking cessation in the general population. And both of those literatures show that e-cigarettes are increasing harm, not reducing harm. And it's very important. This is an area where the literature is developing very quickly now. And I mean, as I said in my presentation, when I went out and looked to see like what's the actual literature on e-cigarette use and disease, I expected to find 15 or 20 studies, and we found 107 using a pretty stiff exclusion criteria. And we're actually publishing an update to that study pretty soon, and the number's up to I think around 130 studies now.
Thank you very much, both. And we need to finish our webinar. And please, Ricardo Gotti, on behalf of the mental health unit of the Ministry of Health of Panama, will be making the closing remarks. Please, Ricardo.
Definitely, this is a call for us to admit the importance of this, and especially to improve the diagnosis of the people with mental illness and to promote tobacco cessation through the strategies that have proven to be effective so far. So with this, I declare that the activity is closed. Thank you for giving us an opportunity to share this time with these wonderful speakers and with all the audience. Thank you, Eduardo. Well, in representation of NATI and Frank Foundation, I am very grateful to the speakers for having joined us in this webinar. Those of you who want to learn more about how to approach mental illness with tobacco cessation, next month we'll organize a case study on this matter. We'll announce it soon. And in November, we'll have a new webinar on cardiovascular disease and tobacco cessation. We encourage everybody here today, people, centers, to join our web networks of healthcare professionals, NATI, to improve our skills in tobacco cessation, and so that we can support the healthcare professionals of all the fields to learn more and to improve our healthcare systems, to make it easier for people to have evidence-based treatments. So thank you. See you next time. Bye-bye, everyone.
Bye-bye.
Ciao. Bye-bye, everyone. Thank you very much.
Bye-bye.
Bye-bye.